Okay, super. Thanks, Cheryl. And do we have any declarations of interest from anyone for this meeting? No, some are shaking heads. Otherwise, we can go on to the minutes of the last full meeting on the 24th of September and also our extraordinary meeting on the 12th of November. Can I ask, are there any amendments or corrections people feel need to be made to those minutes? Take those as read then. That's good. In which case, we'll go on to our service presentation today, which is trauma-informed care model. And I'd like to give a warm welcome to Catherine Evan-Jones. Morning, Catherine. Welcome
Morning.
to the meeting. We're looking forward to your presentation.
Great. And it's actually with Ruben Pierce as well, who I think he's been to this meeting before.
I did see Ruben as well. Morning, Ruben.
Morning, Mark. Nice to see you.
Yeah, so the plan is today for us, I think this is what you wanted, but do direct us if there's anything you particularly want to know more about. So we're going to talk quite briefly about trauma-informed care and safer staffing at Prospect Park Hospital. So I'll start with talking about the trauma-informed care work that we've been doing recently at the hospital, and then Ruben will talk about safer staffing and what we're kind of plans going forward, but do stop us at any point if you want to know more. And I'm a consultant clinical psychologist. I lead the psychological therapies team at Prospect Park, and I do my clinical work on Sorrel Ward, which is our PQ, our intensive care unit. So does that sound about right? Is that what you were hoping?
Absolutely. Thank you.
Yeah, okay, great, good. So what does trauma-informed care mean on our wards? This is quite a nice model. It's sort of relatively simple, but something that we organise ourselves around when we're thinking about what is trauma-informed care. Trauma-informed care is essentially a way of working that sort of recognises the impact of trauma on patients and staff and tries to minimise re-traumatisation. So people have been traumatised before, we're trying to not create more trauma for them, and tries to support safety, dignity and recovery. And I did emphasise the fact that it is for patients and staff. So it's kind of a lens through which to look at all work that we do, rather than something that's kind of like once you've done it, you've done it. It's kind of an ongoing approach, really. So there are 4 R's that are quite useful to think about, and we'll think about what we've been doing on the wards in relation to these. So the first R is to realise. So that's understanding that there is a lot of trauma experience, particularly in the inpatient population. If you're somebody with psychosis, you're 3 times more likely to have experienced trauma in childhood. And so trying to help people recognise this and recognise kind of the pathways to recovery is important as well. So teaching people kind of what does PTSD look like, post-traumatic stress disorder, but also how trauma might come out in different ways as well. And then responding, so implementing a system to respond to trauma. So if somebody has been traumatized, what do we do about that? How do we support that person? And then resisting re-traumatization. So anyone who's been through an experience of trauma is at risk of it being re-triggered for them. So trauma, is often involves powerlessness and having something awful done to you. If we put somebody again in a position of a situation where they're feeling powerless and having something awful done to them, it can bring up their previous trauma and re-traumatize them. So we're trying to sort of be more aware of that for the people that we work with. And often when you're trying to resist re-traumatization, you're focusing on things that might be helpful for people who've already experienced trauma, but generally they're things that are helpful for everybody.
An email from Ambassador.
Oh, don't know if somebody's talking. Yeah, lovely, great. Let's go on to the next slide, Ruben. So this is a very simple way of trying to sort of, again, look through that lens of trauma-informed care. So instead of asking what's wrong with you, which can be a common question in healthcare, understandably, a trauma-informed approach asks what's happened to you. So it's a slight shift in how we look at somebody. So if somebody is at Prospect Park Hospital, there's probably a lot of difficult things that have happened to them. So let's get to know what those things are. Let's understand that person in their context, because they won't be there for no reason. There will have been some pretty difficult things that have happened to them that's probably led to them being here. So the kind of asking what's wrong with you might lead to sort of labelling, things like that, there can be difficulties inherent with that approach, and a trauma-informed approach tries to sort of see somebody more as a consequence to things that have happened to them. So, and essentially within that question is kind of potentially the question of like what difficult things, what trauma has happened to you. So when we've done teaching on Sorrel Ward, this is something really sort of say to people, if you're going to take away one thing, take away this. And people really say it helps them kind of look at things in a different light. So, if you're working on a PQ, there's a lot of challenging or behaviour that challenges that you'll see. There'll be aggression, verbal abuse, racial abuse, lots of really difficult things, which we sort of put boundaries around. But it's also something about, well, let's try and understand that person, understand what's happened to them that's led to this situation. Should we go on to the next one, Ruben? So in terms of what we've been doing on Sorrel Ward, we've been doing all of this within the context of the National Culture of Care programme. So that's been amazingly helpful, because the Culture of Care programme means that on Sorrel we've had fortnightly meetings for the sort of the staff that are involved, and so we've had a nice group of very kind of motivated multidisciplinary staff. We've had the deputy ward manager, we've had other nurses, we've had support workers, activity coordinators, psychologists, OTs, sort of all involved, meeting fortnightly to think about the Culture of Care programme, and trauma-informed care is one aspect of that. So, and again, just sort of highlighted, it is trying to think about trauma-informed care for patients and staff. So in terms of realising that aspect of these are the 4 R's again, we've done some ward-based teaching, trying to help staff understand what trauma is. One of the first things we did as an intervention for Culture of Care, trauma-informed way of working, was to put trauma histories in handovers. So every time there's a handover, which is 3 times a day on the ward for different staff coming onto shift, there now was a very brief 1 or 2 sentence sort of flagging about trauma, so that there's just a bit more context and we understand maybe that person a bit better, and also the 3rd R about respond, maybe understand what we can do differently for that person. And then recognising, so we've talked about with staff how trauma can present, the fact that it might, on RPQ, it might present more as psychosis or mania, but also fear, agitation, withdrawal. Aggression is often a response to trauma. And then resisting re-traumatization. So we sort of try to sort of have quite a interactive discussion with the staff about how do you think we can resist re-traumatization, and gone through so many different situations, observations, seclusion, admission, MDT, ward reviews, all the different aspects. Every different part of that potentially offers, unfortunately, the opportunity for re-traumatization, which we're trying to avoid. So the staff have voted to focus on our ward induction first. So we're currently doing that with the nurses on the ward. And then, should we go next, Ruben? And then what difference is it making? We need to collect more data, but what we know from the training is that staff are finding the training helpful. They're feeling more confident to recognise trauma. So quite a lot of them were already, about at least 50%, so that's great, but sort of feeling like they've got knowledge about trauma-informed care and know what to do to reduce the risk of re-traumatising patients. And we are doing follow-up questionnaires, and people are also saying they're putting things into practice still. They feel like it's changed their practice, but there is more data we need to collect about this, essentially.
Okay, I'll pick up from there then. Thanks, Catherine. So I'll just, I guess, pick up on how this sits alongside our safer staffing work, and how we're building this into the sort of wider culture at Prospect Park. So we use MOST, which stands for Mental Health Optimal Staffing Tool, which is a national tool that was developed to convert acuity and dependency into a suggested staffing level, alongside the clinical sort of judgment as well of the teams. And that's just to describe the demand on each ward and then plan the staffing. So what that means in practice, it gives us a baseline of 2 registered nurses and 5 support workers as the sort of core team on our acute and PQ wards, and 2 and 8, so 2 registered and 8 support workers on our older adult wards. So they're the ones sort of counted on in the numbers in terms of the running of the shifts. But of course, you have your therapies, your psychology, your activity coordinators and medics and so on, which aren't counted in those numbers who attend the ward as well. So we're sort of trying to be very clear locally at Prospect Park that this is the floor and not the ceiling. We don't want to be using most to sort of quietly push down numbers, and we don't ask wards and the staff to work below what is clinically safe. So we would encourage people to highlight where they have concerns and need additional staff, and as long as we can, there's a good kind of clinical rationale or staffing rationale, taking into account sometimes incidents and things like that, then we can look at increasing those numbers. So we know for anybody who's worked on an acute ward, myself included, but even when things look safe on paper, it can still feel like it's not enough when you've got that acuity and that sort of churn and the emotional load's really high. So we have to acknowledge that's a real tension and we have to take it seriously. So I guess one of the questions for us is with our teams day to day, how do we sort of organise ourselves so the care stays as trauma informed, building what Catherine's mentioned, and this is what my next slide is. Where are we, crikey? And it's sort of a bit of an attempt to explain, really. So so really this is about how we kind of enable that, or how we're trying to develop that trauma-informed lens day to day and throughout how we operate at the hospital. So at the top there, we've got kind of principles, language and values. And again, picking up what Catherine said, that what's wrong with you versus what's happened to you. And really where we can, being very careful about how we talk about people, particularly around risk and flow, so we don't slip into that sort of hopeless language, some of the practices that can lead to sort of dehumanizing and labeling people. And it's very easy to fall into that when the pressure is on. And of course, it can really erode positivity for both patients and carers and the teams and staff themselves. So, around there to make things doable, we need to think about a leadership, a team culture and staff support. So it's important that our ward leaders model that language, that trauma-informed approach in our MDTs, our huddles. We think about it in our supervision, our debriefs after incidents, and to really sort of try and tackle that them and us and the results of some of the moral distress of the work that we do. So this includes the sort of support mechanisms we provide for staff following verbal and physical assaults, which Catherine had touched upon as well. Of course, the skills and training and supervision. So so we've obviously heard about the work that Catherine's doing on Sorrel Ward, but also thinking about developing that trauma-informed lens in our risk training, our prevention and management of violence and aggression training, and our supervision that helps staff apply it in reality with patients and have opportunities to kind of rehearse and practice the skills in some of that training in a safe space. So we've also got the sort of personalised approach to risk and safety planning, and we've been doing a great deal of work on that. So it's strengths-based, it's formulation and informed, and the language and the way our sort of forms and documentation are captured on RIO and so forth reflect that trauma-informed lens. So we're really, as far as possible, we can bring that patient and the family story through with that trauma profile, and it's not just about what we're worried about, if that makes sense. We need to think about the environment, the ward choice, and any sort of reasonable adjustments. So we've had the move to sort of single-sex wards with the sort of sexual safety and history in mind. And things like thinking about sensory and communication needs in relation to neurodiversity, as well as some of the race equity work which is underway, which I'll come to in a moment. And then sort of finally, our interventions data and learning. So how we're using our incident and feedback data to shape how we work. For example, using what we learn around observations and incidents to make our enhanced observations less about watching and more about timely sort of relational contact. And as another example, sort of using our patient safety incident reviews to understand what's happened for patients and staff and agree on changes and feed those back to the ward in as trauma informed and sort of blame-free way as we can. So I guess all this sits alongside the safe staffing and not instead of it. And it's a framework that helps us staff or helps us use the workforce in as trauma-informed way as possible. Finally, just kind of difference it's making and what's next. So in terms of what we're seeing on Sorrel, you know, staff have been describing a calmer atmosphere, less them and us. And as Catherine mentioned, some more confidence in how they're working with trauma. Other wards are asking to be involved in this work, so that's nice. That's always a good sign. We've seen some of that, again, positivity from staff perspective in Catherine's pre and post graph she shared. As you say, there's more data to come. It'd be very interesting to see if it has an impact on incident data and reduction of assaults over time, and verbal assaults and things like that. What's still hard, you know, it's no surprise really, it's a balancing of flow risk and personalisation of care when beds are tight. And in fact, even when we're safely staffed, according to the tool, it can still feel thin on the ground on a really busy shift. And you know, again, Catherine touched up on this, staff are exposed to violence, racial abuse, and burnout remains a sort of real risk. So in terms of what we're doing next, we want to kind of build and embed and spread this work. Think about it in induction. Consider how we can improve some of our processes like multidisciplinary meetings. Again, build and improve our PMVA training. Think about how we apply it in our search policy and things like that. And last week we had a race equity review with Sorrel Ward through the Culture of Care programme, with a view to building on our anti-racism practices for staff and patients. We also have some events planned. So we've got an event in February planned for the teams to go and share some of the work they're doing. For example, Sorrel and the trauma-informed work at an event in Oxford with other ward teams from our sort of learning network through Bob and some other trusts to kind of share and learn from other wards as well. But yeah, we have to be honest. It's you know, it's a journey, not a destination. So we're not all going to wake up one day and say we're all sort of officially trauma informed. But I think it's a trajectory, and I think we're starting to feel the culture shift, and we're committed to, you know, to keep chipping away at it. Thank you. Any questions?
Catherine and Ruben, can I just say a big thank you for the presentation. Not only is this really important and valuable work that you're doing, but it touches on so many areas that are often raised as concerns and issues by governors and by us at board meetings. So what you're doing here is very relevant and important to the trust. So thank you for that. Taking some questions. Ros? Are you on mute still, Ros?
Thanks very much for an interesting presentation. It's really good to see that this work's moving forwards. I suppose I am slightly surprised that for what is an outstanding trust, that it's trauma-informed care has been around for some time, and it's only just being developed and taken forwards, but it's good to see that it's happening. Can I ask, are there plans to spread it further afield so that it's not just within the hospital? Will it be within the crisis team, for example, within the community mental health teams? And also, given that the intensive care unit at Prospect Park is now male only and females go out to another organisation at Thornford Park, will the same approach be taken by staff there? Thank you.
Thanks, Ros. I'll start with I think was the first question was around spread beyond just inpatients at Prospect Park. So there is already work underway. We have what we call psychosocial interventions program of work, which we sort of developed as part of the One Team transformation project, which is very much we have a core, an intermediate, and a kind of more advanced version of that, which all clinicians band 3 to 7 are undertaking in the community teams, and that is very much built around trauma-informed principles and values, and there's opportunity to again sort of practice those skills, actually applying those skills in a safe space as part of that. We've also just begun some work, and we've got through about probably 50 members of staff across our crisis teams as well, applying those principles in a sort of crisis team context. So managing phone calls, difficult phone calls and things like that. So there is work underway in other areas. And I've forgotten the rest of the questions. I think it was around, there was one around the PQ and plans to do something over at Thornford Park.
Well,
yeah,
because that's obviously different, and
yes.
the unit there won't be staffed by trust staff, but obviously the approach should be common everywhere,
Yes.
I assume.
Yes.
So what's the
Yeah.
position with that unit?
Yes, that's. I think it's a good question, and I have to say I hadn't thought about it, and it's something we can sort of take away and consider with the Thornford, and see if there's something we can do to support that. Absolutely, that's a good question.
Yeah,
Can I
thank
just
you.
add to
I
that
mean, just on a general level, I think this is something that needs to be thought about for any services that are contracted out, and therefore the staff are not employed by the trust. If we're talking about standards of care across the trust, we need to be aware of anywhere else that's providing services for trust patients. So aside from the work that you're doing, I think it's a principle to be thought about in general. But thank you.
Thank you. I think Catherine might have had something to add as well.
Yeah, I think that's a very helpful point. There's also Poppy Ward, of course, as our acute ward. So yeah, I sort of liaise with their psychologist so I can get in touch with them. And I think it is a really good point to say. We've been working in a trauma-informed way for quite a significant amount of time. So I wouldn't want to sort of suggest that we haven't been. I think this project just makes it more overt and more multidisciplinary. So we've had trauma-informed team formulations at Prospect Park since 2008. We've been focusing on kind of understanding somebody's background and sharing formulations for a long time, I think, and like the PMVA team have sort of incorporated trauma-informed principles in, helping staff understand what it's like if you're being restrained and things like that. So I think this is just the most kind of overt way we've been doing it through culture of care. So yeah, could probably tell you more about what we've been doing before.
Yeah, and I think it's important to find new ways of shining a light on it to keep the flame burning, so to speak. Yeah.
Thank you.
Thank you.
Roz. Megan.
Yeah, thanks. I mean, Roz has slightly asked one of the questions I was going to ask. I suppose my follow-up would be, how well does this sit with sort of social services and social workers? Are they having? I mean, I hear about it in social work as well, about trauma-informed. Is it the same approach, and are you using the same models? That was one question, and then the other question was about the anti-racist work, and in sort of being trauma informed and supporting people at Prospect Park more by sort of understanding the trauma they've been through. Are you then seeing an increase in sort of racist behaviour because of that, or is that just something that you want to sort of deal with alongside the trauma informed work? That was my question.
Catherine, mate, thank you. So if I start with the racial sort of stuff, I think that's been a long-standing kind of issue, and I guess what we hoping is that as part of that anti-racism work, is that we can start to consider sort of some blind spots around cultural competence and that personalized approach in how we develop, and that, I guess, that the history of that person in terms of racial abuse and things, and how that might be impacting, as Catherine said earlier, on their presentation on the ward, and therefore be better equipped to put in interventions and think about how we communicate, or put in very practical things into place, such as considering what shampoo or soap somebody might need for their hair, and things like that. So that was one of the considerations, and the other bit was around the sort of staff support when that does happen, and how we can be better. Sometimes it's, we can't control what sort of comes out of somebody's mouth, but we can think about how we can more adequately support the staff, given their own trauma history of what might be a lot of racial abuse, even from working on the ward. So it's those sorts of things we want to get better at.
The staff have asked us to do more teaching about what it means from a staff's perspective about trauma-informed care, and it was very helpful having the race secretary review last week, because we can focus on kind of race-related trauma, I think, a bit more on the ward. It was helpful. We have been talking about that. We have on the ward, sorry, it's very noisy here, I hope you can't hear it. On the ward, we do have like a safety cross that sort of alerts us to racial abuse every day. What happened yesterday? Was there any racial abuse? But we're just hoping to shine a light on that more and be like, well, what more can we do about it? So we focused quite a lot on communication and how communication can help prevent assaults, as well as other things, difficulties escalating, which might culminate in racial abuse. But yeah, we have plans to try to focus on that more.
And I think in terms of social work, it would be the same kinds of principles that would apply, same kind of model.
Thank you both, and thank you, Megan. And final one, John.
Thank you. Two essential questions. The first is, are you finding that the need for further intervention, the gap between the interventions, is increasing, i.e. it's having a long-term benefit on the actual patient?
I think we're kind of at sort of potentially. Sorry, John, did you want to do the other question first, or do you want me to answer that one?
I think it's going to be easier if you answer that question first.
Yeah, I think we are not at the point where we're collecting data on that, so but we would like to. We are collecting data on incidences. We've also got activity coordinators on the ward as well now, which is brilliant, and that's really helping the sort of atmosphere on the ward and people being more occupied and doing things that are meaningful for them, which is part of trauma-informed care. Well, anyway, so I think, yeah, we can see some individual benefits. I don't really have data on it as such. It's just anecdotal.
Yeah. It's anecdotal. I mean, technically or theoretically, I guess the evidence would suggest that, the more trauma-informed we are, the better, obviously, the outcomes, and probably the sort of journey for the patient through the services, and it should improve recovery times and things like that, and then therefore have an impact on our length of stay and flow and things as well. But yeah, that's probably be part of our kind of next steps, really, is to really get a feel from the patients, whether it's around that patient experience and impact.
And you had a second point, John?
Yes, it relates to indicators for staff welfare. Are you finding that retention, recruitment, sick leave is also benefiting from this approach?
I haven't got the figures, John, but I think I'd have to go to Rose, but I think, and I can follow up with I could always follow up some information, but I think we're doing reasonably well at Prospect Park in terms of staff turnover for for an inpatient hospital unit. I don't think we have turnover, but I don't think it's too dramatic. But I could probably find that out for you and follow up. And oh, Rose is here. There we go, Rose. Thanks, Rose. Saved by Rose.
Hi, John. Sorry. It's significantly lower compared to the rest of the trust for an inpatient pathway. So it's lower than the national standard, but it's also lower than the trust target. So I think when it comes to turnover, sorry, Julian, I think Prospect Park, we're very proud to say, is extremely low, which is very unusual from what I've been told.
So this is something to bang about when it comes to negotiating with powers that be, for want of a better term, for the actual, if you like, amount of salary that can be paid staff. It's working.
There you go. There you go, John. Julian is listening. Thank you.
Thank you, John. And thank you, Rose, for clarifying that. That was really helpful. Thank you. Catherine and Ruben, thanks ever so much for that presentation. As I said before, it's a really important part of work that's being undertaken for us and extremely valuable. So that update was very useful. Thank you.
Thank you.
Moving on, we've now got a presentation from Catherine Humphrey on the carers strategy update. Welcome, Katie.
Morning. I am technically a Catherine, Mark. You did get that right, but only my mother calls me Catherine. Morning, everybody. Yeah, so I'm going to give a little bit of an update on the Friends, Family and Carers strategy. Hopefully I'm sharing and you can all see that. So I'm sure we're all familiar now with the definition of unpaid carers being that family member or partner looking after people because of illness, frailty, disability or mental health problems, and they really can't cope without the support. There's a few stats there to demonstrate this sort of size of the issue, that 1 in 15 people become carers each year. It's having more detrimental effects on people's physical and mental health due to their caring role. And actually, as a working population, we've got more and more people juggling working responsibilities. So we need to think of that as an employer as well. And then also it's quite a changing landscape because every year 4 million people leave their caring role and different people are coming in. So it's a constant cycle of what we need to think about for unpaid carers. And within Berkshire, the kind of stats are similar to the national perspective and some of the things that we need to think about. So in June this year, we refreshed our Friends, Family and Carers strategy and came up with a 5-year plan to take us to 2030. We really wanted to build upon some of the work that's already been going on. So we retained our 6 standards, although we did rejig the order of them a little bit. And then we've also aligned it to our carers charter that we'd recently, over the last few years, developed with carers to know what was important to them. So it's really built around the 6 standards, but comes under these sort of themes of identifying and recognising carers, informing and involving, guiding and supporting, and then that all important piece as well about making sure that staff training and development considers how we're engaging with friends, family and carers, because we know that improving that communication, making sure that we're really respecting people as expert partners in the relationship can have a really powerful effect on the care provided. We also wanted within that to think about the Darzi report and the 10-year plan. So we did manage to include things that aligned to that, because it's really important, and we're seeing a lot more emphasis on better recognition and support of carers, acknowledging that crucial role that they have, thinking about how we can support them with training and resources, recognising that actually caring does have an impact on people's mental health. So people coming to our services either in physical health or mental health settings might actually be carers, and that might be part of why they're accessing our services now, rather than historically it might have been more traditionally that they were supporting somebody accessing our mental health services, and thinking about carers potentially within health inequalities activities, that they really can be considered potentially a social determinant of health. That's what data's indicating. So what we do each year, and we've been doing for the last 3 years, is to have an annual self-assessment within our different teams, and we ask them the teams different questions aligned to the 6 standards, and then we've got a report that has various different ways that people can filter on the RAG ratings that they give to identify quality improvement activities that they can concentrate on. So overall, this year we've just finished the Tableau report, and the summary there is on the left-hand side. That overall, we're looking like we're going in a good direction. But what we've managed to do this year is actually include some comparison data for the last 3 years that we've been running this exercise. So you can see here that actually in 2025, we've got far more green responses on the RAG ratings across the trust, a few amber and then less red. And as you can see, over time, it's gone in the right direction in relation to what we're doing, and that where teams are saying that they've got things in place or that they're looking to address things, and the red areas have reduced, and that is reflected across the different directorates. So mental health has obviously through things like the Triangle of Care been familiar with this therapeutic alliance of involving friends, family and carers. So their figures may look like they're a bit more static, but as we've seen from the work that Ruben and Catherine are doing, it's very ingrained in everything that they're doing as part and parcel of day-to-day activities. So over the last few years, I do come to these meetings and I give you a flavour for some of the things that I've gone too far. That's for some of the things that we're working on. So we are still having all new starters complete our e-learner training. The numbers are still good over all the months. As you can see there, we've had 322 since April. We have, as Ruben mentioned as well, we've got things embedded throughout all the different lots of training, like clinical risk and things as well, and making sure that we're thinking of carers and families within that. We're also part of the refresh for the trust-wide website that's going to be launched in January. We've got 3 new pages and ways of accessing information for carers on the website, so hopefully that'll be launched in January. We're still collaborating and in partnership with our ICS colleagues. I attend the various carer partnership boards. We're working with different local authorities. So for example, Bracknell wanted to adopt our carers handbook, so we've kindly shared that with them. And then Wokingham, Bracknell and Reading are thinking they've seen the e-learning that we do for our staff, and we're kind of in discussions with how we can share that with them so they can utilize it for their staff rather than us all reinventing the wheel. We continue to have links in with the Triangle of Care, linking in with the regional networks, and we've been part of the Triangle of Care's pilot project. They're looking how they can include the patient and carer race equality standards within their existing standards. So there's a working group on that, and we've got carer representation on that with myself. And then we're always raising awareness through things like Carers Rights Day and Carers Week in June. But I thought it might be interesting to share a few different things for some of the different projects that we're working on. So as a trust, we're looking at co-production, and we're making sure that we're really giving teams advice and guidance and coming up with some tools to see how they can engage and involve patients and service users, but also carers within that. One example of a project which we've recently done a lot of, got some feedback, is in our memory clinic review. So we went out across all the different localities, accessed and chatted with carers and service users. Either they might have been things that we were running ourselves, they might have been run by the local authority, or they might have been run by local charities. And we managed to get feedback from about 133 people in the various different groups. And also we had a survey running where we had 50 people. We obviously analysed that and then came out with some outputs. So one of the things that carers said they particularly wanted to do was understand where they were in the process, and that you could have some outputs. So this is a chart that's going to be in the different teams and services that people can use. One of the other projects that people are looking at is the Assertive Outreach team. So Dr. Pooja's been out. They held some other focus discussions looking at how they can engage, looking at crisis risk management, really hearing from the carers with this cohort of patients who perhaps they can't link in with quite so much, to see how they want to engage them in these things. And again, the summary that came through is things like carer involvement, communication, consistency of experience and collaboration, and carer support. So themes that we've already got within our sort of strategy, but we see them coming up again and again. The Mental Health Detentions Act, again, we're looking at advanced choice documents, having that care review, making sure carers' voice is in that, and how we can avoid some of those challenging conversations with things about consent, information sharing and confidentiality. And we're looking at potentially a bespoke carers group for some of those racialised communities so they can share their experiences. Ruben's already mentioned kind of PCREF and the culture of care and how these things all align. And as you can see within that, some of those principles is the trauma-informed approach, the anti-racism work, and they all dovetail quite nicely into having that carer voice within them. And one of the other activities that we're looking at is Martha's Rule, both within Prospect Park in the inpatient setting, working with the team so that they've got an escalation process for patients and families and carers if they feel that they're not being heard on the ward and that they've already raised something there, but then they've got still concerns, and there's an opportunity for them to escalate that process if they're worried about a deterioration in the patient's condition, I should say. And so one of the things that came out of that, to give a kind of a summary of something that's working well, is an idea about this concerns about safety panel. So this is actually working across the different mental health teams, Prospect Park and the community teams in crisis, and it's really an opportunity for us to hear the carer's voice or concerns specifically related to safety. So it's an opportunity for a carer to contact us. Then we'd hold a panel of independent staff based on expertise and experience. They give their clinical and medical perspectives, and then we feed that back to the carers. So it's been happening since April. We've been promoting it through all the mental health teams, as I say, promoting it to families through various different channels like posters and flyers and on the website. The PALS team also has the information, so if someone flags something that they've got concern with, it might be a different way that they can raise a concern. We've had 2 activations to date. Both have been at Prospect Park. One was a carer raising concerns about planned discharge for a patient who'd had prolonged hospitalisation, and the patient was well aware of the fact that their husband was raising the concerns. And then another one was some parents on behalf of someone with a learning disability and some additional needs, where they had concerns that originally she wasn't on Campion ward. So it was really about focusing and listening to the family and carers, and then trying to look at the feedback from that. So what we found so far is that the families have really welcomed that opportunity to be heard and acknowledged and have that practical feedback. The seniority of the people on the panel has been really key to the success of it. We've followed up with ongoing support and written information, but some of the things that we probably need to think about a little bit more was originally we thought the family member would come to the panel meeting themselves, but actually they both chose to have a one-to-one meeting with someone from the panel, and then the panel member fed that information in, but obviously that then has additional kind of resourcing challenges about getting people together in the room, the medics and the clinicians, and the time that it takes to do some of these things we perhaps underestimated, but the powerful impact of what it was we feel is really important that we can continue with it. And then there's things that we do here again and again about communication and jargon, that any communications we've got to make sure they're clear and easy to understand, and that if we are, as a consequence of this, capturing new ways of working as a result of the panel. So for example, in one thing was about joint disability and mental health care and early discharge planning, how we're going to capture and record some of that good practice that's coming out of some of these sessions. So hopefully that's kind of a nice live example of some of the impactful things that we're involving carers with. And then in the future, we're looking still, I've got our goal of having a Silver Cloud program for carers, and also a Sharon for mental health carers as well in the future, so that there can be a resource point for people to have that online support as well, bearing in mind and linking back to some of that digital work that we want to think of as part of the 10-year plan. So that's a very kind of whistle-stop tour of some of the things that are going on, but I'm happy to take questions or give any more information if required.
Katie, thanks ever so much. That really was a tour de force in terms of just how much has been undertaken in this area in recent months, and thank you for that. It was a really comprehensive update. Megan, question.
Yeah, thanks. I mean, that's brilliant. And you will know, actually, Katie, that we've just, Bracknell Forest Council have just done their carers strategy. and I've also been involved in some national work on carers. And two things. One, you didn't really talk about child carers there, and if you did, it was when I went to get a top up of my coffee, but I didn't hear it. So I just wondered, because obviously quite often people with mental health problems, they quite often get supported by their children. So that was one thing. And then another thing that we found when we did our strategy is that quite a neglected group are the young carers, so not child carers, because there does seem to be some support kicking in there for them, but carers from people in their sort of mid-20s to their 40s, they don't seem to have that support network that we're trying to build for them. And I just wondered if you found that when you've done your work in sort of an acute setting, whether or not they've emerged as a sort of needy group as well.
So we're doing so in relation to young carers, we tend to, as you say, I link in with all the different local authorities. So I do head up one of your Bracknell work stream 3 on the link to the strategy. And I know Tom's done some really great work with the young carers in Bracknell Forest. So I tend to link in with the either like in WAM, it's a commissioned organisation, Family Action. So we tend to link in with them and share their contacts and promote that from a young carer perspective to services. We're doing a separate piece of work with, which is linked to what you're saying, but slightly different, but where we have seen is that transition from children's services, mental health services to adults. So from the carer perspective, when you're the parent carer and somebody suddenly hits 18 and then they're an adult, and then are you excluded from all those discussions? And so we're doing a piece of work about that. And we've got a survey out currently because we want to make sure it's very co-produced. So it could either be service users or people that have gone through the process or their parent carer giving us feedback on that. So we've got a couple of people on the project group with that lived experience perspective, so that we're going to move forward with that. So those are the areas at the moment that we've kind of seen touch points on, but you're probably right. There's probably a slightly your 20s to 40s that we've not really tackled yet.
Because obviously, if you're a carer of an older person, those networks that support you feel more at home in, and it's the sort of ones that are trying to kind of build their own identity through their work, through their relationships, being a parent themselves or whatever, and then also having caring responsibilities. I think they're quite a and just on that, I did go and visit Berkshire Healthcare community team for people with learning disabilities, and they were talking about that transition care and parent carers needing support from when their child becomes an adult. So it's good to hear about that as well. Okay.
Yeah, and then but obviously I saw Fiona was on the call here somewhere as well. So in Reading and West Berkshire, when they've got the carers partnership and they've got Promise Inclusion in there as well and things. So we've recently had Mary Derman coming to talk to our staff who are parents of adults who might have learning disabilities, kind of talking about that planning for next steps for when they think they're not necessarily going to be around, all those challenging discussions that you might be thinking and having, and how you actually practically take some steps to control that a little bit yourself. So we try to engage in all those sorts of things.
Thanks, Megan.
Thanks.
And Katie, thanks ever so much. As you know from previous meetings that you've come to present to, this subject is something very dear to the heart of many governors, and so thank you for such a comprehensive run through of the work that's being undertaken. And I'm sure, because you've done it so well, you're going to be invited back very soon for further updates.
Thank you.
Thank you very much. Moving on to Audit Committee, Rajiv, I'm pleased to see you're with us this morning. Do you want to take us through the attachment that everybody has received?
Yeah, thank you, Mark. Yeah, I think everyone will have seen the papers by now. I'll just give a brief summary. So first of all, I think I should thank Paul and his finance team for the outstanding work that they've done during the year, which makes all of the reviews and all of the audits very smooth. Also, I want to thank my fellow NEDs who joined me on the Audit Committee, and the exec directors who also attend the committee for their support during the year. I'll say that if we look at the terms of reference, a quick reminder for everyone that the Audit Committee's purpose is to provide assurance to the board on the effectiveness of governance, risk management and internal controls. We don't review the detailed financial performance. That would be the FIC subcommittee that does that. And we don't review the detailed quality performance. That would be the QUAC subcommittee that does that. We do review the minutes of both of those committees, but more to ensure that the underlying frameworks are robust. For this year, I'm pleased to report that we didn't have any material issues that we've had to escalate to the board. And the assurances we received from the external auditors, Ernst & Young, gave us an unqualified audit opinion on the annual accounts. Our internal auditors, RSM, gave us reasonable or substantial assurance across all of their audits with no high-risk findings. And our anti-crime specialist, TIA, also reported no material concerns. So overall, I think we continue to have a trust that has a strong and well-governed control environment, and the Audit Committee is satisfied that the assurance processes are effective. Happy to take any questions.
Thanks, Rajiv. And can I just say thank you to you in terms of chairing the Audit Committee. There's a lot of detail that I know that you take the committee through on a regular basis. So your chairmanship of that is much appreciated. Any questions for Rajiv and his report? I think they're satisfied by your report. Thank you very much. Moving on to the committees and steering groups, we've got the three groups. Brian, do you want to touch on anything in particular with your report?
No, there's nothing extra to add, and it's brief this time round because we had a shortened agenda, and it wasn't long since we previously reported. So unless there's any questions, that's me.
Okay. And similarly, Sarah, on the quality assurance.
Yeah, I mean, the report is as is, I guess. We had Marie Evans, the clinical director for that came and joined us to talk about the ADHD waitlist that we've been talking repeatedly about. So we wanted to get a view from that. I think there's some further questions that we will follow up on actually within the AOB at the end that have come to light since that working group. But I think the paper is as is. So if everyone's happy with that, then got no questions, then take it as is.
Thanks, Sarah. And then we just have the living life to the full. Any further comments on that?
No, I don't think so. Certainly Brett gave an excellent presentation, and I would actually recommend that anybody who would like to look in further depth goes back to the minutes of the previous meeting, which had a lot more detail in them, and check out the importance and, in fact, how we can encourage the practice and application. Because like all these things, they need finances, and their website does give some excellent help. And Brett is also prepared through his website to answer in as much detail as he can any of the questions that were raised.
Thank you, Madeline. That certainly sounds worth following up.
Yeah.
Thank you all. In which case, we'll move on to the patient experience quarterly report. Liz, welcome to the meeting. We've received your report and had chance to read that. I'm just waiting.
Mark, it will be Trevor joining us today rather than Liz.
Oh, is it Trevor? Sorry.
Yeah.
I was probably advised of that in notes. But
I'm sorry about that, Mark. Yeah. Unfortunately, Liz can't make it today, so I've come along to fill in, so to speak. Just to say, I don't have the same broad view as Liz does. I'm the for people who aren't aware, I'm the patient advice liaison manager for the trust. But so Liz has overall remit for patient experience. But so I've come along today, and you've obviously seen a copy of the report. I'd be happy to try to answer any queries, but otherwise I'll take them back and we'll get a response to you in due course.
Super. As we've had the opportunity to read through the report, do any of the governors have any questions for Trevor? I see some shaking heads. In which case, you can safely report, Trevor, there weren't any questions I've asked that you weren't able to answer. So.
Okay, thanks very much, everyone.
Thank you for joining us.
No worries, thank you.
Moving on to then the trust report, performance report. Julian, who I believe is with us, I've seen him this morning on report. Troy, Julian, do you want to take us through your report?
No, Mark, again, let's just take it as read. There's quite a bit there. And it's always difficult to know what's caught people's interest, because some of the stuff is sort of routine reporting of our kind of performance, which hasn't changed so much. And then there's some updates, including things like our application for Advanced Foundation Trust. People might want to know more about the implications of that, which I may or may not be able to answer. So can I suggest we just throw it open, take any initial queries and see where that takes us in the first instance?
Absolutely. Brian.
Your slides on the application for Advanced Foundation Trust status were more information than I've had from other and previous sources. So the question may be premature, but I'm interested in your view as to, once becoming, if we do an IHO, what scope and content would that contracting that the IHO would do, what sort of things would that involve?
Yeah, so really good question. I'm just going to walk people through to make sure that they sort of get the implications of that question. So effectively, we're a foundation trust. We have been for some time, and we're getting reaccredited. That's the plan in the very first way. So first things first, really delighted to be chosen as the only trust in the region in the southeast to go forward, and only 8 trusts in the country. So they've chosen the 8 trusts who they think are effectively best performing to go through that process. If we jump through all the hoops and we've started that process now and get Advanced Foundation Trust status, there is an opportunity then to apply for the integrated health organisations. This is a misnomer, because you don't become an integrated health organisation, you hold an integrated health contract. So it's a contractual position rather than a change to the organisation. So we will remain a foundation trust, but have the potential to look after and manage contracts that hitherto we've not been able to do. So in very practical terms, perhaps the best example of this I can give is at the moment, the contracts for mental health, not just the mental health services that Berkshire Healthcare provides, but also additional services that might be provided by the voluntary sector, etc. in Berkshire, are held by the 2 integrated care boards. We could in the future potentially say, look, it makes much more sense with our expertise to effectively hold the entire budget for Berkshire for mental health in terms of the NHS budget, and start to think about how we can redesign and redevelop services and have a direct relationship with those other providers rather than having an intermediary body. So that would be one example of an integrated healthcare contract with some of the advantages. If we move to physical healthcare, Brian, you could also say, well, you're doing some really interesting things with sort of GPs out of hospital. We hear all this blurb about neighbourhoods and all the rest of it. If we really redesign services to meet the needs of those people we currently not, particularly those with long-term conditions, that again is a contract that we potentially could hold in order to sort of hold the ring, if you like, but working collaboratively with the voluntary sector, local authorities, primary care, and of course acute trust colleagues. So it wouldn't be holding the entire health budget for Berkshire. We wouldn't want to be sort of overseeing elective sort of operations, but there are clearly things that we have expertise in where you could say, actually, we could take out some of the bureaucracy, bring things closer together, use our expertise in order to make some improvements. So they're the types of things. Now that's early thinking, Brian. We've got to get the kind of rubber stamp first. I'm sure we will. And then we can, as part of that, express an interest in that, and would obviously have to work with the Integrated Care Board. But I have, to date, talked to the Integrated Care Board and our partners about, if we were to go forward, they're the types of things we'd like to be involved in. Does that make any sense at all?
Yes, it does. Thank you.
Sorry, John.
Yeah, same topic. There's sometimes accusations that the balance of staff between administrators and medical professionals is in the wrong favour. How could you control to make sure that the administration becomes more productive, more effective, so that the savings, and obviously there will be savings because it's focused on one point being BHFT rather than several different points, is actually met?
Yeah, it's a really good question, actually, John, and your terminology is spot on. Interestingly, in terms of that, there's usually an obsession by politicians and others around the size of the management of the NHS. In terms of managers per head, we're actually undermanaged compared to other industries and internationally. The NHS, however, is definitely over-administered, with organisations having to answer to multiple kind of regulators, overseers, checkers, which definitely has created an issue. And actually, John, if you think about what's attempted here, in the slides we've sent out about Advanced Foundation Trusts, part of the motivation of Jim Mackey and Les Streeting is to attend to that levels of administration that has crept up since the creation of NHS England post-pandemic, with a number of organisations making sort of template style requests to the organisation. We should be able to take that out. I would be delighted to, so that it becomes a lean operation, well managed, well led, clinically informed, but with a less duplicative and bureaucratic administrative oversight. That would be the sweet spot, John.
Thank you.
Thanks, Julian. Fiona.
Julian, really helpful. Two questions. The first one is kind of related to the Advanced Foundation Trust information that you've presented. I know that the Integrated Care Board are going down their strategic commissioning route at the moment, and they've done a lot of work and papers on that. Can you just explain a little bit more about how that fits in to this piece of work around Advanced Foundation Trusts? And the other thing is that I'm fully aware that they're going through in a period of extreme change and restructure at the moment. And can I ask how that's affecting the trust, if it is affecting the trust positively and negatively?
Yeah, thank you. That's a tough question, the first one. The reason why it's tough is because we're in the middle of a giant reorganization that's been done on the hoof, actually. And there are bits and pieces at the moment that don't fit neatly together in terms of a coherent sort of strategy. But there are things that are starting to emerge that might give us hope, Fiona. So again, this rather grand title of strategic sort of commissioners. So the Integrated Care Boards stepping back, particularly from tinkering and the oversight with providers that they were never in a place to do, and setting out for their geography, with the amount of money they've got, what their priorities are. That's effectively it. And if they really are a strategic commissioner, they then come to other bodies, not just providers, and say, these are our priorities. We want you to collectively go away and work together to fix them within this financial envelope. Because whoever's running it, there is a certain amount of money. And I don't have a problem with that, because I think the way in which we organise ourselves and deliver care is suboptimal. Clearly it is. It's grown over time. We've added stuff, we've added layers. In Berkshire, the voluntary sector really undercut, actually, in terms of kind of how it's utilised, how it's strategically commissioned, if you like, in terms of long-term sort of growth. And the answer I gave to John suggests it. So the strategic commissioning priorities are helpful in terms of giving us some priorities. As an Advanced Foundation Trust, right? The strategic priorities are the exam question, and Advanced Foundation Trust gets the opportunity to answer them. I'm paraphrasing, but back in the days, the worst bits of commissioning was when PCTs and CCGs say this is a problem, and by the way, we've written the plumbing and wiring, we're telling you how to do it, and often it was a madness. How can you do that a million miles? Those closest to the work are always best able to improve the work. So that's the theory, Advanced Foundation Trusts. The requirement of Advanced Foundation Trusts is not to be some independent silo who's got this status and a halo, but is actually a requirement to actually then galvanize partnerships in order to answer that exam question, which is strategic commissioning. I've massively oversimplified it because I know, because the second part of your question is, this is really murky with things happening. And yes, of course, it's affecting us. So the change to integrated care boards, the organisations responsible for planning, purchasing healthcare in their areas, going through a massive transformation. In our area, the two are becoming one, so it's becoming Thames Valley. Staff 2 and a bit weeks ago were told that the Treasury had approved the voluntary redundancy scheme. So now there's lots of people our folks are dealing with day to day who are on the threat of losing their job. Quite clearly, that is having an impact in kind of decision making and everything else. We are experienced, we're a mature organisation, so our approach to mitigate that is to only make requests to them that are mission critical and to stand back and not to expect, you know, perhaps some of the things that you would expect in normal times from them. Why would you? It's going to be very challenging, really. So just home in on a few things, but undoubtedly such change will take a while, and it's going to be a while before it settles down. That's why we have such an important role to play as a stable, high-performing organisation. You know, the challenges that we all face don't change because of the reorganisation. We can lean into some of those, and that will be a significant part of our application, if I'm honest with you. What do you think?
It's really helpful, Julian. Thanks very much.
Thanks, Fiona. And Ross.
Thanks, Julian. That was really interesting to hear about the Advanced Foundation Trust proposal and the potential to be an integrated health organisation. And given that the NHS plan mentioned about governors potentially disappearing, I wondered what this future change might mean and whether that would make any difference in terms of our future.
No, is the answer. So the expectation is everybody becomes an Advanced Foundation Trust. Now, there's about 35–40% of trusts that currently didn't make the original sort of hurdle to foundation. So they reckon it'll be a 10-year process to be able to get them through that process. So if in 1st of April, where, you know, all goes well, and we are designated an Advanced Foundation Trust, there won't be a significant change to the constitution in respect of governors. That would require a change in law, which is not going to happen in this sort of parliament and may never happen. So what I've been saying to people is, look, you know, I don't know what the heck's going to happen in the next thing. I can see through the next 2 to 3 years, which in healthcare is actually quite a long time. There's plenty for us to do collectively as executives and governors and non-executives around this application and the opportunity it brings to bear. And I suspect we may not hear too much for any certainty for a good few years on that. That's the best I know at the moment. So I think as we continue to work positively, as we've shown this morning with the constructive challenge and, you know, the support that you're providing in your subgroups, which is most welcome. And let's just crack on. You know, Fiona provided some context, which is we can either get sucked into the chaos or we can actually start to think about doing what we're here to do. And I'm pretty passionate about the latter, if I'm honest with you. So let's do that together.
Thank you.
Thank you, Ross. And thank you, Julian. If I could just add a little bit to Julian's answer there to Ross. I think we've got a great set of governors and a good form of governance across the organisation. And if we are able to maintain that and demonstrate that to the outside world, whether it's regulators or whoever may observe that, you're providing a really strong case for that. that it brings to the organisation, and that we should continue doing that going ahead. Thanks for your time this morning, Julian. Moving on to Governor feedback session. Is there anything governors wanted to feedback in terms of the contacts they've had or meetings they've been involved in over the past few months? Brian?
Yeah, something that came up this morning actually, and we discussed in the governor's pre-meeting. On BBC Radio Berkshire this morning, the presenter covered off the Berkshire Healthcare pausing of adult ADHD referrals. And that's the first I'd heard of it. Two of my colleagues in the meeting had heard that from Autism Berkshire, and there is a note on that page of the Berkshire Healthcare website. Now, what I will do, because it needs a considered answer, is raise a governor's seeking assurance question via Rachel for the short-term future. But I was just wondering if Julian, you could comment a little on what we have heard about from outside of the trust.
Yeah, I certainly can do. Yeah, we can sort of pick up perhaps afterwards about how you've heard about it, but it is correct. So the adult ADHD service probably established about 12 years ago, and we were paid and planned to do 100 assessments a year, and that has grown to many thousands. If we got to a point where we were accepting referrals where the wait list will be over 20 years, and we think that's morally and ethically wrong. We have worked hard with the ICBs, both of them, to say this isn't right. You know, we can't be doing this. This is no way to treat folk. And we have agreed that there will be a pause to our wait, but that Berkshire residents will be able to be channeled through to both private sector providers, so that through the right to choose, so they'll still be able to get their assessments, but obviously much shorter, whilst we work through the wait list, and also be referred to Oxford Health. So Oxford Health paused their waiting list, they've just reopened it, and whilst they paused it, we actually ended up taking obviously Oxfordshire sort of patients. So within the Berkshire geography, those people still needing assessments can be referred. It just will be that Berkshire Healthcare is not providing them. So there is still a service for Berkshire residents. It's just that we won't be providing them.
Okay, supplementary question, if I might, just for a brief comment. The comment that was sent to the BBC radio station also mentioned something about medication shortages. Is that the case, and how serious is that?
Yeah, it's been so for ADHD, there has been a national shortage of medication for about 2 years. It has been hugely disruptive. So this is a national known issue in terms of supply lines. The reasons for it are potentially multifaceted. One of them is the demand that has gone up exponentially. So this is obviously a kind of national issue in terms of the demand. So the demand for that. And secondly, it's supply chains, because some of this stuff is coming from Europe and overseas. So those two things, demand and supply from pharma companies, has created quite significant change. So people have had to change medications, and that involves restarting and titrating onto a new regime, which then has required our staff to be involved additional work to resolve an issue that would normally be sort of, you know, a steady ship or whatever. So yeah, it's been hugely disruptive, and at a national level, it's been one of the kind of major challenges for a couple of years now.
Thank you. Sharon.
Hello there. This question's to Julian. Julian, is there any chance I can have rehabilitation put on the February agenda? Because I have a very good idea. We do not have rehabilitation for addictions and stuff like that. I think there's maybe a handful of rehabilitation centres. Now, I'm hoping that maybe the governors might support me in this, and yourself as well, that we can go to the supermarkets, because the top people in the supermarkets, and actually ask them to help fund more rehabilitation centres, because the best person to actually spot a shoplifter is an ex-shoplifter. The best person to actually do security is an ex-burglar. The best person to do hacking is an ex-hacker. So in my area in Slough, it's basically the local petrol station has had to put a metal screen around them, and also the other day when I went there, I run over a basket. These companies are losing so much money. Their staff are at risk. The security is not allowed to do anything, and also the shoppers are at risk. So they are losing billions of pounds. So I'm thinking, if we as a trust get together with the top people in all the supermarkets, because people shop in there as well, and get that money, because they're not getting any money back for the stolen goods. They're not getting any help for their staff. The security ain't allowed to actually, stop these people like they used to years ago. So that money's going down the drain. So why not help the trust to actually give more rehabilitation centres? Because most people with an addiction will tell you, I want to get off the drugs. I want to get off the drink. And we have a very good charity in Slough. I'm sure you've heard me say, Shock. There is nowhere to send, excuse me, nowhere to send these people. They're expected to do home detox, and they have to jump through several hoops with Turning Point. You've got to clean yourself up before we'll turn you. What we want to do, I think, is actually, sign them up for rehab, get them back into society, and maybe working for the supermarkets as security, as shelf stackers. Because once addiction hits you, you cannot do it on your own. And a lot of these people are on the streets, living in tents in Slough, and basically not getting the help they need. They can't do home detox. Most people that suffer with addictions don't have homes. They sofa surf.
Sharon, thank you. Thank you for that. Julian, do you want to respond?
Yeah, I think a couple of points I guess I can sort of pick out of that. So if we take the rehabilitation in terms of employment, Mark, that is something that we do, and we could certainly do. I don't know last time or where we have recently done a presentation on our individual placement support team, which we certainly had at the board meeting in terms of helping people back in or remaining in employment. It's quite a significant service. If we take addictions, Sharon's right, it's a major issue for us. So across the patch we cover, we've got 6 different sort of services provided, commissioned by local authorities. You've got Turning Point in Slough, it's different in the different teams. And the opportunity for residential rehab and detoxification, those services have been cut. So they're impacting us all. And we probably need to have a think, Mark, about how we can talk about that. So, for example, quite a lot of our services work with people with codependent, sort of both mental health and addiction issues, and do have a good relationship with their addiction service in their area. But I agree with Sharon, there are some very significant gaps, particularly in terms of what's available. And our crisis teams, for example, often struggle when they know that really there's a primary addiction and it's not really getting kind of resolved. So we probably need the employment bit we can most certainly do. And then we just need to think about how we cover off the issue of addictions, which is hugely impactful. It's one of the highest risk areas, not just in terms of sort of acquisitive crime, but also in terms of harm to the individual, deaths rates, etc. So we really just need to have a think about that, Mark. We can rally around and think about what we could do on that.
Thanks, Julian. Sarah.
Yeah, thank you. Thank you, Julian, as well. If I could just take you back a little bit to something you were just saying earlier on the ADHD waitlist, if that's okay. I think there's a general feeling of some reassurance is probably needed, I think, on those waitlists. And just to put it into context, right to choose for the GP surgery, there does need to be better improved communication into primary care to ensure that they are actually supplying up right to choose opportunities for patients. There are GP surgeries refusing RTC, so that does create a bit of a challenge there. The second route is, are we assured that those providers that are being put forward are able to provide the medication? Because they have to be, I think they have to be a specific level or type, forgive me, I don't know the correct term on that one, in order to do that. And obviously that will then just impact, they'll have a diagnosis, but where do they go? And I think the third point I'll just ask is, how can we also make sure that that service, there is no effect, and children's services waitlist will not be closed as well, because that's a significant problem. So there's 3 questions in there, Julian, and I appreciate you may not have the answers for all of them today. I'm happy for you to come back.
You know, it's an age thing. I genuinely am not. I remember the third question, but not the first. Go on. What was the first?
So the first one is really about the primary care piece around, GPs and right to choose.
Yeah.
And communication to them needs to be made. So that's number 1. Second point was medication, and making sure those providers are able to provide. And then the third point is reassurances on children waitlists as well.
Okay, I've written it down now. So yeah, the kind of right to choose. So this is a temporary measure. Okay, so the amount we're spending as an economy is dwarfing other areas of mental health where the risks might be even greater. So because of this, so one of the things that we're doing is looking at, whilst this pause is going on, is working with the ICB, taking a kind of quite a lead role about what the future provision of service kind of looks like. So this is a temporary kind of measure whilst we do that. So in terms of the right to choose, GPs have been communicated with, and they've also agreed. So there was a number of GP practices who were, for understandable reasons, because GPs are under pressure, not engaging in a shared care protocol, which again would have allowed us to work, in terms of increase our capacity. We have agreed that, which is positive, so that will be helpful. And the ICB are communicating their kind of position. I cannot account, however, for exactly what will happen in an individual consultation in primary care practices. Some are better than others, but I am assured that engagement with primary sort of care is happening. In relation to the right to choose and those providers who have been selected, a number of providers have been deselected as a consequence of the sort of a quality assurance process. And the cost of the assessments and the quality of the assessments has been monitored as far as practically sort of possible. And then the third is, this is an adult thing. We've done a lot of work on children's, and that has been really helpful. And we're not, as a consequence, planning to make any further changes there, although the National Task Force is really clear about this, which is, it's not sustainable to be doing all these sort of assessments. It's about actually getting the kind of reasonable adjustments and everything else. And ultimately, we ought to be thinking about the less complex diagnosis happening in primary care over time. But at the moment, whilst none of those changes are happening, we are maintaining our service, and we're sort of maintaining the lists where they were. They're not sort of radically going up and they're not radically going down. We're sort of maintaining a steady flow. We should note that we are, for the population we serve, above average in terms of the numbers coming through. ADHD has a correlation with deprivation, and we are actually doing more assessments than per head, 100,000, than my home city, which is quite remarkable, really. And we need to ask ourselves questions about that too.
Okay, thank you, Julian.
Thanks, June. Thank you, Sarah. Sophia.
Thank you very much. I think Sarah, you've already asked a few questions that I wanted to ask. Yes, related still to with the ADHD pause for the adult service. Sorry, I think I completely agree with Sarah that service users need to have reassurance that paused is what is happening, and hopefully this will not be forgotten. As I understand, so now we have, yes, great that this right to choose will still be carrying on, but as you just said, Julian, it is a temporary solution. So if temporary, we hope that we'll be on time to unpause and continue when that when we're not able to continue with the right to choose, because one thing that I think it's very important, and I think a lot of people forget about is the part about neurodivergence, be it ADHD, ASD, or any other, in relation to adults, in particular women, because it is high, the demand for assessment and support for a reason, because for decades it was misdiagnosed or ignored, and I think people are finally getting clarity about their minds and their needs. So this is really important, and being an advocate for equity and inclusivity and specifically neurodivergence is something that I think it's very important. Another point that I wanted to make, Julian, you said about the GP clinics or medical centers not all engaging with the right to choose. I have to me that has happened where I think it's, you all know, right, that I am neurodivergent. I've been recently, so I'm one part of the lost generation, as we call it, in research. So I've been recently diagnosed with ADHD and ASD, autism spectrum disorder, and while I went through right to choose, because I think I had already waited many years, then the people that from that right to choose clinic, or they contacted my GP because they required an EEG from me, right? Oh, well, that would be done, and actually they bluntly refused to do it because they said it was a private organization, and I explained that it was right to choose. So I think maybe it's just an outlier, but it is important that indeed all GP clinics are aware of what they are supposed to, how to engage with right to choose. And finally, when you mentioned reasonable adjustments, that it is very important. Indeed it is, but in many cases, reasonable adjustments depend on a diagnosis, a formal diagnosis or assessment. Being at university, being a, well, so again, some of you know, being an academic and dealing with students day to day, they can get, if you're talking individuals that are in higher education, I don't know about post-education, but higher education, there is, you can get an assessment, albeit it's not medical assessment, it's more of an education-based assessment for certain different types of neurodivergency. But if we're talking about staff in organizations, you require a proper assessment for any reasonable adjustments to be considered. So I just wanted to leave that out there, part of my experience and part of my views. Thank you.
Thank you for sharing that, Sophia. And Megan, is your hand raised?
Yeah, but I was going to go back to what Sharon was saying about drug and alcohol rehabilitation. So I don't know. Is that okay to go back to that?
Yeah, if it's brief, we will need to move on, but no, we've got time for one final point on that.
All right. I just wanted to say, obviously, as a councillor and also a cabinet member for public health, we commission drug and alcohol services, but we're actually in the process of recommissioning. And our current drug and alcohol service isn't particularly amenable to people with a dual diagnosis, so an addiction and a mental health problem, which struck us all as quite crazy. So I suppose my question to Julian is this something where we should be looking at how public health works with the NHS? Because to me, it just doesn't sound like a great system. And if we're having this huge sort of change of the NHS and the 10-year plan, is this something and we're having this whole treatment to prevention hospital to the community, is this something which is maybe slightly sitting in the wrong basket? And should we actually be looking at as a sort of a national change in policy of where these services kind of come from? Or do you think there's ways of getting around it?
Yeah, it's really interesting, Megan. I'm going to frustrate Mark now with a less than pithy reply, but I'll do my best. 14, 15 years ago, it would be routine that a trust like ours would provide the range of services for substance misuse. So that would be drug and alcohol, although in reality, the drug side predominated for a variety of reasons. That specification included providing services for dual diagnosis right through to sort of, early help. So it was the lot. And that was what was taken into local authority commission services when public health went that way. And the reality of it is, Megan, long before you became in the role you had, because of austerity and everything else, guess what? Those expensive services get cut. To do a genuine dual diagnosis service, you do need consultant psychiatry with expertise in that. And the only way you can train up in consultant psychiatry and addictions is to work in an addiction service. We don't have them. And as they small, so there is a problem to be resolved. Nationally, I'm not sure it's top of the pops. Do we want to resolve something more locally? Yeah, and that might be the conversation we can start to have here, about how we might work together to do things differently. It is highly specialist, it is high risk, and the current offer is frankly subscale, as is never going to meet the needs, as Sharon has already talked about, really. So there is definitely a need for some change. I haven't got all the answers, by the way, but the current way isn't working. Sorry, Mark.
No, that's useful to have that, and I think it's an area for further discussion in the future that needs our attention. So I'm sure we'll be hearing more of that. Moving on as we need. Is there any other business from anyone in the meeting today? Looking around. John.
Yes, thank you. Julie, thank you. I'm now in my 5th year as Public Governor for Reading, and the support that you have provided to governors has been most useful. And I would like to record in this council minutes our thanks for that support.
Thank you. I think that's very well said, John, and the comment that us as NEDs often pass around the boardroom table about the support to both the governors but also to the board as well. So thank you, Julie.